My name is Dr. Adam Slivka. I'm at the University of Pittsburgh Medical Center here in Pittsburgh, Pennsylvania. I'm going to discuss our manuscript validation of the diagnostic accuracy of probe-based confocal laser endomicroscopy, or PCLE, for the characterization of indeterminate biliary strictures, results of a prospective multicenter international study. PCLE is a form of in vivo microscopy, and the probe used in this study is the cholangioflex probe, which I have here, which is a very thin probe that can fit through a 1.2 millimeter channel and can be delivered during ERCP through a catheter or through a cholangioscope to direct contact with the bile duct epithelium to visualize structures both around and within a stricture. It's got a 40 to 70 micron depth of penetration and a 3 to 4 micron resolution, and so structures can be seen on a cellular level in real time during the ERCP. Pioneering work by our colleague Dr. Alex Meining in Munich, Germany, demonstrated that this probe could be used during ERCPs to evaluate strictures in the bile duct in patients. Alex was able to describe criteria seen on the PCLE probe that represented the normal bile duct and noted that it was very different from the elements seen in patients with malignancy. As a result of Dr. Meining's work, a group of investigators, myself included, met in Miami back in 2009 and viewed multiple videos provided by Dr. Meining of both normal and cancerous bile duct epithelium as visualized by PCLE, and came up with criteria to describe normal bile duct and cancer. These criteria were known as the Miami criteria. Following this, we embarked on a large multi-center registry in which we used these criteria in a large number of patients who were being evaluated by PCLE with indeterminate strictures. The results of this study demonstrated that PCLE had a very high sensitivity of 98% in patients with indeterminate strictures. The specificity was 67% and the overall accuracy was 81%. Thus, PCLE compared very favorably to tissue sampling, and a negative PCLE study highly predicted the absence of cancer. However, we still had problems with specificity and false positives. A group of investigators met in Paris and developed a second set of criteria known as the Paris criteria to describe inflammatory changes. These were not normal bile duct epithelium, and these were not cancer. Preliminary studies demonstrated that including these Paris or inflammatory criteria improved specificity. However, these criteria were not validated in a large prospective study. As a result, this current study was undertaken with the aim of validating the PCLE using Miami and Paris criteria in real time during ERCP in patients with indeterminate strictures. This study represents a large multi-center study with 4 U.S. centers and 2 European centers. In this study, we evaluated 112 patients prospectively, and we found that doing an ERCP and PCLE resulted in a sensitivity of 89%, a specificity of 71%, and an accuracy of 82% when the physician made a clinical diagnosis during the ERCP in real time. When combined with tissue sampling, our accuracy went up to 88%. This compared very favorably with the retrospective data that had an accuracy of 79% of ERCP and tissue sampling without PCLE. The results of this study demonstrate and validate the high performance of PCLE when performed during ERCP. particularly when combined with tissue sampling. We believe that this technique has the potential to reduce the number of diagnostic tests these patients are exposed to over time, and may also hasten the diagnosis and result in catching these cancers at an earlier stage. We also learned that the quality of the image in PCLE affects its performance characteristics. Fortunately, 75% of patients had image quality that was deemed good or excellent. In this subset of patients, the diagnostic accuracy was significantly higher than in those patients in whom the image quality was felt to be only fair or poor. In the subset of patients with good or excellent image quality, when combined with the results of tissue sampling, the accuracy was well over 90%. So what then is the future of PCLE for indeterminate strictures during ERCP? Clearly the technology needs to be disseminated more widely. One of the important components of this is in coding and reimbursement, and the company is actively working to obtain CPT codes, and the data from this manuscript will be used in that process. In addition, the ASGE has put out position statements and guidelines recognizing the role of PCLE in managing patients with indeterminate strictures. The company has online training programs designed to teach individuals the criteria involved and the methodology used in order to obtain high-quality images. Smart atlases are also being developed in order to assist users in discriminating benign from malignant findings, and this should assist in the dissemination of this technology. Finally, we are engaging our pathology colleagues in order to correlate the descriptive findings seen in PCLE with the anatomy seen in histology. Interestingly, we are learning that many of the structures we see are destroyed during the fixation process and have led to the development of some exciting findings that correlate with the PCLE descriptive findings with structures that were not recognized by the pathologist who were viewing fixed specimens or cytology. Further collaboration with pathology with anatomic correlation will likely lead to improved performance of PCLE, not only during ERCP, but as well as other GI luminal applications, including in the esophagus and colon. We conclude that PCLE should be added to the armamentarium of therapeutic endoscopists when performing ERCP and evaluating patients with indeterminate biliary strictures.